I'm Dr. Jean Huddleston. I am a practicing hospitalist and industrial engineer at Mayo Clinic. My parents think I'm absolutely crazy because after 15 years into my career at Mayo, I decided to go get an industrial engineering degree. And my father wondered what was wrong with the degrees that he paid for, that I had to go do yet another one. I did it because healthcare is broken. And I grew up in Michigan, which is the automobile industry in the world, right? And I distinctly remember when I was about 14, my dad drove home. We had a big Ford car, one car garage. He drove home in a Nissan 280ZX with T-top windows and an 8-track player. It was and it was red. It was the coolest thing I'd ever seen, but he wouldn't drive it to work, and he put it in the garage and left it there. And I couldn't figure out why. This is about 1980, 79. I could not figure out why he would purchase something and then not drive it, because it was a really neat car. So I asked him, I said, what's up? He said, well, it's more reliable, it's cheaper, and it looks better. So for his value proposition, that's what he wanted. So now, fast forward a number of years, when he was 80, he bought a Corvette. So he still, and he drives it everywhere. So he turned that around. But that's why I went back to school, and that's why I do this work. And we'll get into more of that story. Our work is founded on something we call the loved one's lens. So I am willing to tolerate a fair amount of system and process failure as a hospitalist. I have to break through it, I have to go around it, I have to do all of the extra things to get things done for my patients sometime that should happen more seamlessly. Anybody who's been in clinical practice knows you have to do all those end runs. Pyxis went down at Mayo Clinic for almost a day. Our pharmacists were hand creating packets and running them to the floors, which is crazy, right? So stuff happens. So this particular patient went to a critical access facility and was found to be in complete heart block after she fell a couple times at home. That's my mom. She had just gotten out of the hospital, and the doctor had prescribed a new dose of metoprolol. She was managing her own medicine box, and this is 10 years or so ago. It was before her subdural hematoma and real cognitive decline, so she was doing all right. She was taking both doses of the metoprolol, the one from before and the one she was just given. And the only way we found that out is I flew home, because I was losing my mind, took all of her pills and found both bottles of metoprolol in her pill box. I'm like, Mom, what are you doing? I said, well, the doctor told me to take it. He didn't tell me to stop the other one. So she was just, and so nobody did anything wrong, but my mother ended up in complete heart block with a pacemaker and flown to a large hospital. 2 days before that, we were at the Derby. So we were celebrating my birthday, and my dad bought Derby tickets, and we got a chance to go to the Derby, and it rained the entire time. My mom fell when we were there. She was walking kind of weird, and I didn't pick up on it. I missed it. Maybe it was the alcohol that pours so freely at the Derby, I'm not sure. But she was 90% chance she was in complete heart block when I was walking around with her, and she was so unsteady. And then I found out afterwards that she had gone off by herself and thrown up while she was there. So there was a lot going on, and I missed it, and that was the result of that. So at the IHI forum this last year, we put up a whiteboard and asked people, what would you worry about if your dearest loved one was hospitalized? Anybody want to raise their hand and say anything? What would you worry about if your dearest loved one?
What are they missing?
What are they missing? Anything else? Infection.
Are people competent?
Very good question. Yes?
Communication between teams.
And with the patient? So this is what they told us. I took all of the things from there and I fed it to Copilot and said, make me a word cloud. This is what came up. It's kind of cool. But you can see that delays were a huge thing. That's the biggest thing. That was the most common. But delays in treatment, delays in diagnosis, delays in procedures, complications, nutrition, palliation, honoring wishes. Those were the things that came up. So I asked Copilot to go back through 10 years of adverse event, peer-reviewed publications, and find the top words. We use a different language than what we worry about. And so we find and we report these things, not the stuff we would actually never leave the bedside of our dearest loved one for. So to me, there's a disconnect there. When you look at them next to each other, there's a disconnect. And I started this work in 2003 to make an impact on that. Because the stuff I worried about when my mom had her cabbage, I wasn't worried about the procedure, the surgeon. Infection actually never crossed my mind. Delayed rescue of deterioration for a cognitively impaired person on opioids. That's what I was worried about. And in our rules, our rapid response team criteria is a pulse greater than 130 and a blood pressure less than 90. And then we decided that we would give the residents and the interns and the faculty, everybody, 2 hours to fix that if that was the case for somebody on a general care floor. I lasted less than 5 minutes when my mom's blood pressure hit 60, and I was in the hallway. Yet we expect people to wait. My mother-in-law, who had her renal cancer resected or nephrectomy last January at Mayo Clinic, so both of these are in my hospital where I work. They kept her in the PACU for 6 hours because her blood pressure was in the 80s, and they didn't want to send her to the ICU. So they sent her to a general care floor at 1 o'clock in the morning with her blood pressure in the 90s, her pulse in the 120s, still completely unresuscitated, down 4 grams of hemoglobin, out of her mind, and they called our behavioral emergency response team twice in 2 days. Now, why didn't I feel empowered to go in the hallway then? Why wasn't I on the phone with the surgeon? Eventually I was, but there was a lot. I would say, hey, can we get a liter of fluids? And the nurse would go, I'll call the resident, and we'd get a liter of fluids. So I was running the resuscitation as the daughter-in-law instead of being the daughter-in-law. So what happens to other patients when they don't have the advocates? So our systems are perfectly designed to achieve the results we present to our leadership. Right? We get these adverse events. We get these voluntary reports. We do our RCAs. Peer review's got something going on over here. We make pretty data and charts, and we give it to our leadership, and what happens?
Another error.
The same thing happens again. So results, if I look at it mathematically, as a geeky engineer, system plus design equal results. We started the patient safety world before to err is human, saying results were human failure. We got better in the last 25 years, and high reliability came up, and all the DMAIC and lean and all of that stuff, and so now we're in the world of results equal process or system failure. I think we need to be in the world where results equal the system and the processes and the humans. A human design element, so innovation in that world. And I believe that we need to bring humanity back to patient safety and quality. So I kind of look at it like this. The fruit is the result of healthy growth, right? So those would be our outcomes. Those would be the good outcomes we want. Some very pretty fruit. We've got great mortality, great readmission rates. Nobody's falling. We haven't had any decubitus ulcers. We haven't had it to report anything to the state this year. Nice fruit. To me, then, the leaves are the patients. And they bear the fruit. What happens to them becomes our outcomes. The roots are all of our processes and systems. They're in place, they're rooted you can, if you actually printed them all out, God knows how many pages there would be. But we've gone to great effort to improve the care, and progress has been made. So if the systems and processes are the roots, and the leaves are the patients, and the fruit are our outcomes that we report to our leadership, what's the trunk and the branches? Our care team members. The life within them, their capability to think and feel and be compassionate, empathic, and take care of themselves, that's the water that's coming up from those roots. That's the nutrition that's coming up through those roots. And when our staff aren't healthy and they're not doing the things we need to do, follow the guidelines, all that sort of fun stuff, if they're burned out, what happens to the quality of our fruit? Because the number of leaves have gotten bigger. So what happens to the quality of our fruit? It gets worse. Our outcomes get worse. So that was sort of the mindset that I had back in 2003, and those of you who have heard me speak before or who are working with me now know this story. I get a phone call from the chair of our hospital practice committee, which is kind of like the hospital board. And he says, "Huddleston, fix mortality," and hangs up. Like, all right, I'll get right on that. Who's dying? Is it the inpatients? Is it the outpatients? Is it the surgical? Is it the medical? Is it the ones that come in from the outside or the ones that come through our ER or the direct? Who is it? So as a clinician researcher in epidemiology, we decided we needed to approach it in a way that we could actually identify where things were broken so that when we had resources to fix something, we would fix something and it would actually fix something. And you could see the outcome metrics. So our leaders only know what they know, and it is sitting at the tip of the iceberg. And for those of you who can think back to your geology days, 90% of the iceberg's below the surface of the water. How many people have functioned and lived underneath the surface of the water in your facility and watched things go sideways and have absolutely no power to make it better? That's how I felt at that time when I was given that mandate. And so we decided that we were basically going to do an epidemiology study of mortalities in our hospital to figure out who was dying and what we could learn from their deaths. How could we honor their lives? That was the thing we brought in. So we had 3 hospitalists and 1 nurse. We reviewed 100 cases, and we found, 50% of the cases had serious issues. You'll laugh. The top 3, this is 2003, so it's 22 years ago. Top 3 were delayed recognition of sepsis. We called it paleopenia because palliative care didn't exist then. So osteopenia, not enough bone, paleopenia, not enough palliation, and deteriorating patients in the hospital that at the number 1 facility in the country, we couldn't tell they were dying right in front of our eyes. What are the top 3 that we're seeing now across the country? Sepsis issues, palliative care issues, and deteriorating patients that go unrecognized. So our theory in our research project was that we could name, define, and quantify the things that were going on below the system. So when we validated or reconciled what we found with what was in the voluntary reporting system, RCAs, and all that sort of stuff, 0 of what we found. And in those 100, we hastened the death of 5 and ended the lives of 3. And they were reported nowhere. When I was asked to give that presentation to our public board of trustees, it's our public board of trustees that said, this is how we're going to find what we need to fix. And so the mandate came up from high. In the back on the table are publications. The Learning from Every Death was our first 7,500 consecutive mortality reviews at Mayo Clinic. We were doing 100% mortality review then, and it is our journey and how we decided to do what we do. It took us 5 projects. So we went after deteriorating patient. At that time, it was our number 1 thing. And we found 5 failure modes that were completely different issues. Not calling the RT when the criteria are there, not recognizing how sick they are, not treating them as intensively as they need to be for the severity of illness, communication and teamwork, and escalation to a higher level of clinical experience to make sure that the right people were at the bedside. 5 projects, 18 months, statistical drop in our mortality rate. It's going to take more than one big thing, because those big things are done already. And it needs to be done on a outcome or on a failure mode that is frequent. If we stick with preventable errors, preventable adverse events, and that's the only thing we go after, 5% of our patients that die had a preventable death. We have 1,400 deaths a year. So just rough math, if I fix 60 of them, because they were preventable, and those are the only ones I'm willing to look at, will I move the needle for our leadership? No, it's it's mathematically impossible to do that. You've got to go after the things that are frequent. Goals of care conversations, deteriorating patient, sepsis, et cetera. So the other paper that's back there is the publication that came out just 2 weeks ago from the Learning Collaborative that's had over 100 hospitals in it that has contributed to the development of this work and the creation of the framework that drives change and brings the humanity back into quality improvement. I'm not going to spend a lot of time doing this, but I am going to say the analyze and identify patterns. That's where we decide something's high frequency that's leading to death. Aspiration. You find that? You've got beautiful aspiration precautions. They've been implemented everywhere. There's a standard practice. So why did aspiration come up as the #1 thing and when one hospital did 30 consecutive reviews? I don't know. So let's look at the patients. Who are they? Every single one of them was a hip fracture patient found down at home, lived alone, very frail, unknown period of time down, EMS to the ER, NPO on admission, went to surgery, ICU, delirious at all get out, post-anesthesia and opioids, fed, aspirated, and died. All of them had respiratory failure and died. We don't need to fix the entire aspiration protocol. This is not a 2-year project. They didn't get their 3-ounce water screen, so we didn't know they were at risk. And believe me, when they come out with post-op with all the meds on board and everything, and they're even worse now. So before we feed someone, we need a 3-ounce water screen. It was so far down the nursing work list because 5 days had gone by that it didn't happen. So when I write a feeding order and the patient hasn't had a 3-ounce water screen, that goes, because you think about that order to feed people. There's something that goes to dietary, there's something that goes to nutrition, there's something that goes to the nurse manager, there's something that goes to the nurses. Why can't it include 3-ounce water screen? Easy fix. Nobody knows. So it's those sorts of things that we're looking for. And as a clinician, when you tell me that my favorite patients in the world, hip fracture patients, aspirate because they don't get screened pre-op, that matters to me. As a hospitalist, when I walk in that room, this wasn't my hospital, but when I walk into any room, is there like something in that plant? When I walk into any room of an elderly, frail patient now and they've got a tray and they're laying in bed, I pull the tray. Understanding the physiology of what's going on and seeing it happen into a group of shared experiences in different floors, taken care of by different surgeons and different nurses, and they all aspirated and died. That's something I can fix. I know what to do now. We've got to figure out a way to put these things together so that we're communicating to the frontline care team about something they care about. I just came off a 9-day hospitalist stint, and I wondered, why in the world did I used to be able to do 14 and 21 days when I barely survived? Well, some of it's 20 years have gone by, but the other part is I didn't have interns and residents with me either, so I was completely alone. If you had come to me and said, need to follow the sepsis guideline more, on day 4, I might have smiled and been polite. By day 9, I might have dropped an F-bomb. I've got no room. You haven't told me why, but if you tell me that our geriatric patients when you don't follow the guideline, have an X% increase in mortality for every hour we don't treat them, and it gets done faster when they use the sepsis guideline, I'm going to use the sepsis guideline because I don't want those people to die. But no one's ever come to me for change and actually made it about something I cared about. So we use, within the collaborative, so over 100 hospitals. So we have to have there's standardized education, standardized training, and this is all based on case reviews. We have to have a shared definition of what an opportunity for improvement is. We don't use any of the traditional patient safety language because I believe that that changes the conversation with frontline healthcare team members. So we use opportunity for improvement, and the number one opportunity for improvement we find is gratitude. And the staff in the hospitals doing this work actually send thank you notes to this person, the ER doc that had a goals of care conversation within 5 minutes of arrival. If you thank me for that behavior you want me to do, guess what I'm going to do? I'm going to do it again. Yes. So tying into some of that, but our definition is, could I passively watch my dearest loved one go through what I'm seeing in that chart? Or would I have been in the hallway looking for somebody? If I would have been in the hallway, or it would have made me sick to my stomach, or uncomfortable in any way, it's an opportunity for improvement because the care is not good enough for my loved one and therefore not that patient in that bed. So when we teach people how to do the reviews, we teach them to put the loved one lens on, which is basically for that patient, age, gender, whatever, who's your dearest loved one that's kind of like them? Imagine them in that bed, imagine that face in that bed. Now read the story of their experience. Don't do a chart review. Read the story of their experience. That's where we find more stuff. And most of them are omissions of care. So this represents more than 19,000 patients. We now have over 22,000 patients that we've studied using this exact same methodology. And the cases are reviewed by a frontline nurse and doctor. And the reason that that's important, in reliability science, you defer to expertise, right? Deference to expertise. So if 80% of what we're identifying are omissions, not commissions, that means I have to find what's missing. How in the world do I find what's missing if I don't know what's supposed to be there? So we tap into that clinical expertise to identify what they see happen and what they want to see improved. And end of life was the biggest one. 56% of the patients all had end of life, followed by documentation, just a little bit of copying and pasting going on across the country. Treatment and care, those are usually delays. Delays in treatment, delay in procedure, delay in getting to the right place, wrong treatment selected, et cetera. Followed by communication and deteriorating patient and delayed or misdiagnosis. Now, we all know for the Pareto diagram, you look at the 80%, you work on that stuff, and you forget the 20%. The darker bars are our reconciliation between what's in our system and what was in their patient safety system. So they reconciled what they found with our methodology versus what was in RL Solutions or Midas or whatever. And the dark blue is what they found. The lighter blue is what we found. And the stuff that they're finding, believe it or not, is the 20%. So if you want to statistically improve your mortality rate, your readmission rate, your sepsis, acquired sepsis, whatever it happens to be, you need to study them like a researcher studies it, and then identify what needs to be fixed that's the higher volume, target it, fix it, and honor those lives. 97% of the hospitals that do this work started with mortality review because, I don't know, that's just where people start. And you can see all the other different types of things that people look for. We have critical access facilities that looked at falls. We had critical access facilities that looked at delayed transfers to higher levels of care. Pediatric patients in the emergency room. So a large spectrum of the things that people are interested in, and they don't review them forever. They review them until they have enough cases to actually find clusters of similar experiences, determine what's broken in the system, fix it, and then they go on to the next thing they're interested in. Maybe it's maternal mortality, maybe it's PSIs, maybe it's readmissions, maybe it's falls. Study those, figure out what's fixed and who it's broken for, target it, and save some lives. This is through the end of 2024, and I bring it up because documentation has now superseded end of life because hospitals are putting things in place. And I don't mean bigger palliative care teams. I mean other things in place to address goals of care, palliative care, suffering at end of life, respiratory rates in the 40s for 24 hours prior to death, with comfort care orders in place. Things along those lines. So here's the iceberg. The iceberg's back. Now, we'll see if we get the 90%, or with the title of my talk, did I get the 80% right? So on the left-hand side are unique patients. 81 had voluntary reports that were not identified through our process. Those are very often mechanical failures and the sorts of things that don't get reported or written down in the chart. Believe it or not, there's a lot of falls in there that don't get written down in the chart. 278 patients had events in both, and 857 patients had events in ours, and prior to this work, there wasn't a single leader in their institution that knew that those things were happening. If the leaders don't know it's happening, they can't ask to have it fixed. Number of events, 604 that we didn't find, 80 that were in both, 4,193 events that nobody knew about. 58% patients, but 84% of the events were below the surface of the water. Now, as a frontline healthcare provider, I'm not surprised at any of them. I could make the list for you. But no one's going to listen to one voice. We need volume of patients with multidisciplinary voice in the mix, and then surface that to leadership. This is all about leading up. This is completely designed to lead up. Now I've got a chance of making a change. Who cares, right? This is what you take to your leadership. I have told every hospital I've ever worked in, don't start with a documentation and communication project, please. It won't work. I'm not going to listen to you. I've got other things going on, like trying to save lives, to worry about how I document in Epic or how I communicate with the nurses and all of those things. Until now, when we did a study, so this analysis, everything, they're controlled for age, gender, pre-hospital code status, end of hospital code status, I mentioned age, and clinical diagnoses. So taking all of those other things into account, let's see, documentation costs us 3.5 days of length of stay. I'm going to have to think about that one because I just, communication is this one here, 5 days length of stay on average. There is some beds. Anybody trying to build another bed tower? Here's your beds. End of life. And I don't just mean that's the green. And this is compared to 7,000 patients who had no opportunities for improvement at all. 4.5 days length of stay. And that basically is a group of patients who didn't have goals of care conversations. They had code status conversations, maybe. But they were all full code. And very typically, they're all full code. When I started my hospital service and did that 9-day stretch, in the first 2 days, I had 4 patients with liver failure or metastatic cancer. One of them had had no chemotherapy in 3 months, and she couldn't figure out why her oncologist wasn't scheduling her. And they were all within 6 months of dying, but they weren't dying at that moment. I got all 4 of them into hospice, and they all went home with their family. They were full code when I walked in the door. It's that, and they'd already been in the hospital for a week. So it's those sorts of things. And then the top part and the bottom part, the top part's all patients, and the bottom who don't have that same OFI, and the bottom part are all patients who don't have that exact category. So there's multiple subcategories under each. This is a simulation of increasing number of omissions of care. So it doesn't have the same impact as commissions, so your acquired sepsis, your acquired infections, your falls, but it is not chump change when it comes to the number of beds that you could free up. Doesn't take very many goals of care conversation within the first 24 hours to get the return to hire another nurse or a chaplain to have those conversations. We're not going to go through this because we are at time, but this is in the conversation, and this is the back of the napkin exercise that I took myself through that I shared with our leadership about what we needed to do around end of life, documentation, communication, et cetera, because they need to see numbers and dollar signs, but I always start with the stories. So it's the stories and the data. And I will hang out here and answer any questions whatsoever, but I'm so grateful for your time and your generosity for us coming in from the nice weather and the food and the other stuff that's out there. So thank you very, very much.